Chief Operating Officer for NIHB. I'm glad to be with you to introduce this informational webinar on a topic that is of utmost importance, COVID-19 vaccine development and distribution. We have several federal agencies represented on this call, including the federal government's Vaccine and Countermeasure Task Force, Operation Warp Speed. Before I introduce our speakers, I'd like to introduce our organization for those of you who may not be as familiar with the National Indian Health Board. The National Indian Health Board is a nonprofit organization that was created by tribal leaders almost 50 years ago to serve as an advocate for all federally recognized tribal governments to ensure that the perspectives and the voices of the tribes were heard in all policymaking decisions that touch on health and public health in Indian country. We're governed by a board of directors drawn from every region of the country, and we do our work in partnership with national tribal organizations, area Indian health boards, regional tribal organizations, and of course, with tribal leaders and citizens from across Indian country. To get us started, I wanted to provide some level setting and share what we hope this information session will do. This session is geared to provide foundational information to assist our tribes before regional consultations take place on the vaccine distribution planning. Those regional consultations will be held next week, and we have republished the consultation schedule on the NIHB website. That is on our landing page. Also, and specifically, we wanted to provide a grounding on a number of documents that were released last week by our federal agency partners. Some of you may have seen some of those documents. We have a playbook around vaccine distribution and allocation. There are lots of decisions that need to be made by our tribal leaders, and our tribal citizens also want to share information with our tribal leadership and with the federal government. So we thought this would be a very important topic to bring to all of you before those consultations get underway. I also want to be clear that this call will not focus on vaccine trials. We know that there are a lot of questions coming up around the vaccine trials, and please do reach out to me or reach out to anyone from NIHB if you have questions on the vaccine trials, and we will do our very best to get that information to you. But I wanted to just make sure to kind of do that level setting. Our presenters today are not really involved as much in the vaccine trial element of the work, so they have more of a limited scope specific to what I just mentioned. I encourage all of you who are listening in by phone to join us on the Zoom if you're able to, since our presenters do have slide decks and that information will be presented visually. For those of you who cannot join us on Zoom right now, you will be able to view the slides after this webinar. They'll be posted on our webpage along with a recording of this webinar. We ask that if you have colleagues who are not able to join us today but are interested in this information, please do direct them to our website. Without further ado, I'd like to introduce our speakers. So first up, we have Marion Whitaker, Senior Executive Service, and she is serving as the Deputy Chief for Supply, Production, and Distribution for Operation Warp Speed. The next speaker after Ms. Whitaker is Amy Groom, who is a Public Health Advisor with the Centers for Disease Control and Prevention. And after Amy, Ms. Groom, we have Rear Admiral Francis Frazier from the Indian Health Service, who is the Director for Public Health Support at IHS headquarters. Rear Admiral Frazier is an enrolled member of the Cheyenne River Sioux tribe. So with that, we will go ahead and get started. Thank you.
Okay, this is Marion Wicker. Am I coming in over?
Yes, you are.
Great, thank you so much. Good afternoon and good morning, ladies and gentlemen. I know we're talking to people all around the country, and so some of you may be still earlier in the morning. As Carolyn introduced, I'm Marion Wicker. I am the Deputy Chief for Supply Planning and Distribution from Operation Warp Speed. And it's my pleasure to talk to you today, talk a little bit about Operation Warp Speed and go over what the program is. I know we've got speakers from the CDC following me, so I certainly won't steal any of their thunder. So Operation Warp Speed is a combined effort between Health and Human Services, and the Department of Defense, with the goal of delivery of 300 million doses of an effective vaccine to the American people going into early 2021. Immediately upon FDA either approval or authority, we will begin starting to distribute vaccine based on an allocation. And the allocation, the CDC will be talking a little bit more about that. The vaccine, the goal is to give every American the opportunity to have a vaccine should they desire so. I know there's always a concern about a safe and effective vaccine and what are we doing about that. Science and data will drive the decisions of OWS as we move forward from research and development into safety trials, large clinical trials, and then ultimately into the manufacturing of a vaccine. We'll talk more about some of the vaccines that we're doing. But as I mentioned early on, it's a collaborative environment. It is Health and Human Service, it is Department of Defense, it is industry, it is academia, and of course it is partners like the Indian Health Board to help us bring all of this to fruition. All of this talent is required to develop the vaccine and then bring it across safely. So what are we doing to make that happen? Number one, clinical trials. I know Carolyn said we won't talk about clinical trials. I'm certainly not an expert in clinical trials, but I will give you a little bit of information to tell you where we are from perspective. As we go through clinical trials, there are various ones, level 1, 2, and 3, and we'll talk about some of the vaccines. But we have really harmonized the effort so that we have clinical trials set up to test an appropriate population, have all the equipment in place, and then achieve the effective results. Manufacturing and fill finish. Ensuring that we are able to manufacture a vaccine once one has been proven effective, and being able to do the fill finish is critical. And so simultaneous with our clinical trials is we're making sure that we have all of the manufacturing network set up as well. Once a vaccine is approved, the distribution becomes important. And so we've developed a detailed strategy to include a playbook that Carolyn referenced earlier, and I know Ms. Groom will talk about later, to really guide states, tribes, territories on how we're going to implement the vaccine program. And then last and certainly not least, administration. We will be taking a lot of efforts in order to make sure the vaccine gets out to all the population. I know there's concerns about populations that aren't normally covered with a pharmacy or in a very rural area. My own personal state from Michigan where I'm at, there's concerns in the Upper Peninsula. How am I going to get it up north? All of that will go into the distribution and administrative strategy. We are very fortunate to have McKesson as our distribution partner. The CDC was able to exercise the pandemic option of their normal procedure, and McKesson is our central vaccine coordinator. In addition to McKesson doing the central vaccine, they're also building the ancillary kits. So in addition to the vaccines, the states and territories and all of the people getting the vaccine, ancillary kits, which will include needles and syringes, alcohol prep pads, a reminder card, as well as masks and face shields for the people administering the vaccine, will be provided as part of that whole vaccination process. And so I know that's an important question that's also referenced in the playbook that we'll talk more later. A lot of people ask, how are we doing it so quickly? A lot of the efforts are doing things in parallel rather than the normal sequential process. So as we're doing late stage clinical trials, we're ramping up the development of the vaccine, being able to produce it. And when we have a vaccine that's been determined safe, first and foremost, effective, then we're ready to push vaccine right away. And so I want to assure people that no one's cutting corners. We're doing all of the things, more actions in parallel than you probably would have seen. Again, the science will drive what we're doing. OWS has a commitment to transparency. It's calls like this. We have a website. If you go to the CDC website, you'll see the linkage to COVID and all the things we're doing. And so I encourage people to look for our media reports, look for webinars such as Carolyn is hosting here today, and any of the other media things you see. I was asked to address a couple of things about some of the vaccines. So the United States government is working on 7 vaccines themselves, but there are also other vaccines being sponsored by public universities. Other countries are doing their own. Most of the vaccines will be a 2-shot dosage, anywhere between 21 to 28 days in between the vaccines. Clinical trials, again, I know Carolyn said we won't talk a little bit about it, but I'll give you a little bit of information. So right now we have 3 vaccines that are in active stages of clinical trials. The clinical trials are operating with a goal to have up to 30,000 people, and we certainly want a mix of society to test each one of the vaccines. So each clinical trial, again, a goal of 30,000 people to enroll in those. Moderna and Pfizer have been in their clinical trials since the end of July. And then Janssen, Johnson & Johnson, recently moved into their stage 3 clinical trial. And then the last thing I would just like to talk about, and it'll be a good segue to when Amy Groom gets up to speak, is, as Carolyn mentioned, on 16th September, the CDC released the vaccination program playbook for all of the jurisdictions. This document covers the specific COVID-19 vaccination program and how we're going to administer that. And I know Amy will talk about that. The last thing I'd like to do is also introduce, and many of you may know him, Captain Rob Hayes volunteered to come and join Operation Warp Speed. So Rob is representing Indian Health Services, a vital member of the OWS team. And so I just want to thank Rob for his service not only to the Indian Health Service, but now coming over and to join us on Operation Warp Speed. Carolyn, I'll pause there.
Thank you. And I will just mention that we are going to take questions. We have a question and answer period at the end of the hour. So if folks are having questions, we just ask that you hold them, type them into the chat box, and then we'll pull up those questions and go over them at the end of the session.
Great. Ladies and gentlemen, thank you for the opportunity to address you.
Thank you, Marion. We'll move on to Ms. Groom.
Hi, good evening and good afternoon, everybody. This is Amy Groom. Thank you so much for you participating in the call today. It's great to see such broad representation across Indian country on this call. Carolyn, are you able to hear my audio?
Yes, we can hear you, Amy.
Great, thanks so much. So I'm working currently with CDC's Vaccine Task Force and focusing specifically on the distribution of vaccine to tribes and urban American Indian Alaska Native communities. Next slide, please. And I do just want to acknowledge that the information is rapidly evolving around the vaccine. And so the information that we're sharing with you today is based on the current information. And as that changes, we certainly remain committed to communicating that with you. But today, what I wanted to cover are some of the current COVID-19 vaccine distribution planning assumptions, and also provide just a very brief overview of the playbook that Marion referenced regarding how to plan for vaccine distribution that our states and jurisdictions are using. And then finally, my colleagues from the Indian Health Service are going to review the potential COVID-19 vaccine distribution scenarios for tribal and urban American Indian Alaska Native communities. Next slide, please. So I know this is a rather daunting slide, and Marion actually gave a very nice overview around the safety checks that are currently involved with the vaccine development. And I just wanted to put this up here to illustrate for you. This demonstrates the vaccine life cycle from the very beginning of vaccine research to the very end. And all along the way, you can see there are numerous places for safety checks. And Marion certainly explained that some of what's happening with COVID vaccine in particular, given the urgency, are parallel processes, but the safety checks are still in place. The third dark green bar is the phase 3, where the vaccine candidates that are most likely going to be available first are currently in that phase. And you can see that even upon completion of those phase 3 trials, they still will need to undergo FDA review. So there will be additional safety. So I just wanted to reiterate that there are safety checks all along the way in the process and the development of the vaccines. Next slide, please. Once we have an authorized or an approved vaccine from the FDA, we will have to obviously get into thinking about how we will implement and use that vaccine in our communities. And so this diagram is basically just laying out those steps. And what I wanted to just highlight here are the first 3 pieces, because that's really what we're going to be focusing on today in this presentation, and really look forward to getting your feedback in the consultations next week. Those 3 phases are the prioritization of population, so which communities or which populations will receive the vaccine first if we have limited supply, and then what are our processes for allocating and distributing the vaccine. Next slide, please. So I'm next going to go over some of the key assumptions, and as I stated earlier, information is rapidly changing and evolving, and that may mean we need to change our vaccine planning processes, but these are some of the key vaccine planning process assumptions that I wanted to share with you today. So the first is that limited doses may be available by the end of 2020, but we're definitely going to see an increase in 2021. But the point is that initially we are going to have limited vaccine supply. Any vaccine that is made available will either be approved as a licensed vaccine or authorized for use under an emergency use authorization that's issued by the FDA. As Marian referenced, there are a couple different vaccine candidates, and the cold chain storage and handling requirements are likely going to vary and can range anywhere from a vaccine that needs to be refrigerated or ultra cold storage. And I'll talk a little bit more about that later. And finally, as Marian also referenced, most of the vaccine candidates are likely going to require 2 doses for immunity. And so those will need to be 2 doses of the same product, and they'll need to be separated by 21 or 28 days. Next slide, please. Some additional planning assumptions: any COVID-19 vaccine and all the supplies to administer that will be procured and distributed by the federal government at no cost to enrolled COVID-19 vaccination providers. And as I mentioned, because of the vaccine storage and handling complexities, as well as some of the reporting requirements, which I'm going to cover in a little bit here, we're really looking at distributing these COVID-19 vaccines through the existing clinical and health infrastructure. As I mentioned, there will be 3 potential cold chain parameters that need to be considered, from refrigerated vaccines, which is very similar to what we currently have for most routine vaccination. There are also formulations that potentially will need to be stored frozen, and also those that will need to be stored at ultra cold. One of the notes that I want to make is that even if we end up with an ultra cold product initially, we are not recommending that administration sites purchase ultra cold storage equipment. If we have an ultra cold vaccine, it can be shipped from the manufacturer in packaging with dry ice, and it can be stored in those containers for an extended period of time, and you could then even replenish the dry ice. So there's no need for potential administration sites to go out and purchase ultra cold storage equipment. They can be shipped from the manufacturer in those conditions. Next slide, please. So one of the assumptions that we also are making is that the initial vaccine supply is going to be limited initially. And because of that initial limited supply, administration sites are going to need to identify the priority groups in their communities for vaccination. The Advisory Committee on Immunization Practices, or ACIP, is deliberating this, and they will be providing guidance on priority groups. However, we also recognize that tribal governments get to determine the populations that they serve, and they will need to identify the groups in their community for initial vaccination. Next slide, please. Even though we don't have the ACIP's current priority groups, there are some critical populations that will likely need to be prioritized early on in the process. Those include our critical infrastructure workers, so that's healthcare personnel, but also police, teachers, and others that are essential to the functions in your community. We also believe that people who are at increased risk for severe illness need to receive vaccine in the early phases, and this can include the elderly and anybody with underlying medical conditions that might make them at increased risk for severe illness. This also includes certain racial or ethnic groups that may have been disproportionately impacted by COVID-19, and that certainly does include some of our tribal communities. Other groups that are critical are those who are at increased risk of acquiring or transmitting COVID-19, and that includes individuals living in congregate settings such as long-term care facilities or in prisons and in schools. And then finally, we want to make sure that people who have limited access to healthcare and to vaccines receive the vaccine, and that can include folks with disabilities, but also I think particularly relevant for our tribal communities are those that live in very rural or isolated areas with limited access to healthcare. Next slide, please. So CDC did release what we're referring to as the Playbook for our state and jurisdictions on September 16th. And as you can see here, it covers several different phases and things that need to be considered in developing a vaccine plan. And so states will be using this as the backbone as they develop their vaccination distribution and implementation plans in their states. And those plans will be due to CDC on October 16th. Next slide, please. One of the things that I did want to cover are the required reporting for COVID-19 vaccine. And I think this is particularly important because in addition to the cold chain issues, some of the complexities around reporting need to be taken into consideration. And this is another reason why we're really looking to the existing clinical and health infrastructure for distribution of COVID vaccine. Administration sites are going to need to provide daily reporting on certain required data elements, and there is a complete list of all of these elements in the playbook in one of the appendices. But just to give you a flavor of some of the information that will be required, it will require inventory reporting, so doses received, doses wasted and expired, dose level administration data, so the facility as well as details about the patients who receive those vaccines, and of course information about each individual dose of vaccine. And these are all elements that most clinics are actually already collecting and reporting. And so really looking at the systems that are in place to both collect this information and then to transmit this information to either the state or to IHS to get to CDC is going to be a really important piece of determining which vaccine distribution model will work for you and your communities. And then of course, in addition, we need to make sure that systems are in place for reporting any adverse events associated with vaccination. Next slide, please. And finally, there is definitely a lot of concerns around a vaccine hesitancy. And in order to be really successful with this, we're going to need to partner and communicate with our communities about the benefits of the vaccine and address any concerns that emerge related to the vaccine. And so this Vaccinate with Confidence framework is something that we are looking to. It was originally developed because of a measles outbreak, but I think it's very applicable to COVID vaccine. And it really just reminds us that we need to reiterate our goal, which is to protect communities first and foremost. And as part of that, we need to stop myths and misinformation and figure out how to get accurate information to empower our providers and our families and our communities to make informed decisions around COVID vaccination. So we remain committed to working with you and look forward to your feedback on how we can help to support communication around COVID vaccine with your communities. So next slide, I'm actually going to end there, and I'm going to turn it over now to Admiral Francis Frazier with the Indian Health Service, who's going to provide an overview of the IHS activities around COVID-19 vaccine planning and to share with you the proposed COVID-19 vaccination distribution model for the IHS Tribal and Urban Indian Health System. So thank you, Carolyn, and I guess Francis is up next.
Thank you, Amy. We'll go ahead and turn it over to Rear Admiral Frazier. Okay, just please, everyone, hold on for a moment. We are trying to find Rear Admiral Fraser. It may be that he's having a little bit of technical difficulty. Rear Admiral Fraser, if you're with us, you will need to press *6.
Can you hear me now?
Yes, we can hear you. Thank you.
Oh, very good. I'm sitting here talking away. Thank you.
We do that all the time now with this virtual world that we're in, but I'm glad we can hear you.
Okay. Well, thank you, and thank you for pulling up the slides. And I would like to just thank everybody for being on this call and providing the opportunity to present some information in addition to what you've heard from Operation Warp Speed and from CDC. In the Indian Health Service, with this situation that we're facing with the COVID pandemic and activities that have been presented up to this point, the Indian Health Service has formed a COVID-19 vaccination task force. Amy Groom covered some critical components to vaccine implementation in her presentation. And what we've done in the Indian Health Service is we've developed a task force to address those specific components. If we could go on to the next slide, I just want to do a little stage setting here. As you all know, the pandemic has disproportionately affected American Indian, Alaska Native populations across the country. We are at 3.5 times more likely to be infected with COVID-19. And we do know about the countermeasures, and we all strive to practice those activities, but that COVID vaccination remains one of the most promising countermeasures to reduce the disease burden and morbidity and mortality for our American Indian and Alaska Native people. We're working with CDC and Operation Warp Speed, and as was mentioned on the call, we do have Captain Rob Hayes assigned to Operation Warp Speed, and that's very helpful for those operations. It's very helpful for all of our communities in Indian country. If we go to the next slide, I just want to start out with sort of setting the stage on what do we know. We know, and it has been reviewed here, limited COVID-19 vaccine doses will likely be available during the fall. The supply may increase substantially into 2021. So initially, those COVID-19 vaccines will either be approved as licensed vaccines authorized for use under an emergency use authorization by the FDA because of vaccines are being studied in certain populations and without additional co-administration of other vaccines, they won't be able to be co-administered with any other vaccines. And they'll need to be used in specific age categories they were studied in. So this is just sort of, level setting. Once authorized, as Amy Groom had talked about, the 2 doses of the vaccine will need to be separated, 21 or 28-day periods. And so that those vaccine products and second dose reminders for patients will be necessary. So when we think about tribally operated health programs and Indian Health Service health programs and urban Indian programs, these are some of those factors that start coming into play. Those doses will need to match each other. They'll have to be of the same product. And we have to think about those operational activities and how we're going to track those activities in addition to, the previously mentioned cold chain storage and those handling requirements. It may vary from product to product. So, all these factors come into play from an operational perspective. It was also mentioned about ancillary supply kits being included, and those kits will contain enough supplies for 100 doses of vaccines. Additional supplies, gloves, Band-Aids, sharps containers will need to be available also for vaccine administration. So again, sort of focusing on that operational issues that we will be facing. If we can go on to the next slide, please. Thank you. So CDC is considering Indian Health Service a jurisdiction similar to a state. What does this mean? It means that the Indian Health Service, our ITU programs need to be prepared as soon as the COVID-19 vaccine is approved and available. The Indian Health Service does recognize that vaccination is one of the most effective prevention strategies, and we have prioritized this within the Indian Health Service we've been operating under an incident command structure since the pandemic has started. And again, we are taking this, this is high priority for the agency. We've formed a task force to address the vaccination plan in utilizing the guidance that has been previously referenced from Operation Warp Speed and CDC. And we are planning for early limited vaccine availability. We can go to the next slide, please. So again, I'll focus. This is just to focus more on sort of a timeline. Initially, the Indian Health Service, we sort of approached this in a phase approach. We started pre-planning activities in June. There was a request, and we supplied personnel to look at supplying some clinical expertise within Indian Health Service for some Tiger teams that were going to sites looking at assessing states regarding vaccination plan activities. And what the Indian Health Service did, the Incident Command, we formed a work group under the Incident Command structure to start looking at these activities. As information has become more clear, we started looking at planning assumptions. The Indian Health Service had decided that this needed to be elevated higher up. We needed to tap on expertise across the Indian Health Service, and so we formed a task force, a transition to a task force. And our goal is to get a vaccination plan completed in October of 2020. If we go to the next slide, please. So the structure for the task force is comprised of 6 teams, and that includes broad representation from within the agency. These teams work together. We're going to ensure that IHS is ready to vaccinate our workforce, patients, and our patients as vaccine becomes available. And so our teams really, if this is where I talked previously about sort of the structure of these teams. The distribution, prioritization, vaccine administration, communication, and data management and safety and monitoring. Sort of when you look at the information distributed by CDC, you'll see that the team structure in IHS sort of mimics those key areas. So I just want to take a minute just to touch on each. If we could go to the next slide, please. So under prioritization, we do have a medical epidemiologist who is the team lead for this activity. And what they're focusing on is identifying the critical and target populations to inform our allocation strategies. Okay, so this information may be based on estimates, on available information from the ITUs. We will be transparent with this information, and we will communicate to our stakeholders with this information. And this is, I think, a real critical piece. And again, remember, so Indian Health Service, we're focused more on operationalizing these activities, and tribes will have that opportunity to further prioritize, allocation strategies within their programs. But I'll just give a quick example. If we know we're getting theoretically a limited vaccine supply initially, If a program has prioritized their healthcare personnel as first that need to be vaccinated, and let's say a program has 100 healthcare providers, but you only receive vaccine for 25 healthcare providers, how do you further define who is that essential group? So, again, I just sort of frame that in an operational sort of context. We go to the next slide, please. So distribution allocation, this team is responsible for identifying and enrolling ITU programs to receive IHS allocated vaccine. They'll be responsible for developing facility agreements, tracking vaccine distribution, inventory, approving vaccine allotments based on allocation strategies. Additionally, they'll be identifying storage capacity and storage needs, and ensuring that supply of additional the supply of additional vaccine supplies that will be required. Next slide, please. And these slides will be available also for all of you. The vaccine administration team, it will be responsible for developing tools and resources needed at the local level. And that's for administration and documentation of the vaccine, as well as provider training, dose recall strategies if that needs to occur, event planning assistance, developing clinical content for communicating to our provider staff and to the public. And next slide, please. So our communication team, again, is going to be a key piece, and this really builds upon my previous statement. We really want to make sure that we're clearly communicating well to our internal and external audiences, that we're making sure we're providing that information, getting the announcements out there, coordinating activities, making sure that information is disseminated. This is a very important team within the task force. If we go to the next slide, please. And of course, data management. I know Ms. Groom from CDC did reference some of those reporting requirements. This team is currently working closely with CDC to make sure we're identifying those needs for appropriate vaccine documentation at the local level. And this will be ongoing work, making sure that we are capturing all the information that is required. If we go to the next slide, please. Safety and monitoring, of course, is always a concern for patients served. The safety and monitoring team is responsible for ensuring information provided through the vaccine adverse event reporting system is analyzed and it's reported. This team will look at providing education information to the field. We want to make sure we're disseminating any information that regarding vaccines as quickly and efficiently as possible. If we go to the next slide. And so I wanted to just, sort of pose some things for consideration and for next steps. So if IHS is allocated a vaccine, think about what is this is useful for planning or for planning purposes, and we want to hear your feedback on this. When you think of the best model for COVID-19 vaccine distribution for your programs, for whether you're served by a direct service program, whether you're served by a tribal health program, an urban Indian program, if you think of what is your existing immunization structure like, for both adults and or children. How does that work right now? How can that be leveraged with COVID-19 vaccine distribution? I think it's really important to assess that, because that, whether it's your vaccine services are administered by IHS or a tribal program, that infrastructure is in place, and is that the best mechanism for receiving COVID-19 vaccine? So, you know, we want to look at that, look at those distribution pathways, you know, confirm what they are. You know, I think it's variable across Indian country in the way both healthcare and vaccine distribution occurs, and so that's why we want to hear your feedback and think about and make sure we are you know, discussing and considering those views for your circumstances. And with that, Ms. Hornbuckle, I will stop.
Well, thank you very much for the presentation. And we have a bunch of questions in the chat box. And if it's okay with folks, I actually would like to go slightly out of order, because I think that we have some kind of threshold questions that might be really good to talk about to begin with. And I will just invite our panelists to respond if it's a question that you have a response for. So one of the questions in the chat box was, how does a hospital or clinic become an approved provider? Will IHS or tribal facilities be approved to provide the vaccine, and will this be automatic? And that kind of just takes off a little bit on what you were just talking about, Rear Admiral, about the pathways and some of the questions that will be coming to the tribes next week in consultation. So could you or could Ms. Groom address that question?
I think it's you know, as I sort of alluded to in some of my discussion or in the presentation, I don't think we have to look at what is the current capacity for vaccine administration at a particular site. And so, like, with that question, I don't really know what the situation is or how vaccines are administered at the current time at that location. But that's the you know, when I start thinking of the infrastructure, the provider infrastructure, the vaccine storage capability, what is it for that specific site? And you know, is that infrastructure in place to be able to do the reporting and the you know, administering those vaccines on a you know, a specific you know, for that, whatever the requirements are for that vaccine. Amy, do you have anything to add to that?
Yeah, sure. Thanks, Francis. I think really just getting to the crux of the question, which I think is about automatic enrollment. None of the clinics will be automatically enrolled. Sites that want to administer COVID-19 vaccine are going to need to enroll as a COVID-19 vaccination provider. And there's really two pathways at this point in time, and that will be making the decision of whether you want to receive that vaccine through the state, in which case you would enroll through the state's process to become a COVID vaccine provider, or if you want to receive your vaccine through the Indian Health Service, you would then go through the enrollment process with the Indian Health Service. So Robert, I hope that addresses the question.
Thank you. And we have a couple of other questions, which I'm going to just tick off just in the interest of time. I know we don't have a whole lot of time. So there's a question, are states, the question just moved. Are state health departments required to engage in tribal consultation to ensure underserved tribal community input in the state plan for COVID-19 vaccinations? So question about tribal consultation and how is that going to be done at the state level if the state is working with the tribes to administer the vaccines?
I think it's a really great question, and I can't really speak to tribal consultation requirements at the state level. I do know we are committed to engaging in tribal consultation, and for tribes to have the choice about how they want to receive their vaccine. And once that choice is made, then that would be communicated to the state, and if they choose to enroll with the state, then the state would need to account for the tribe in their vaccine planning and distribution. Or if the tribe chooses to enroll with the Indian Health Service, they would work with the Indian Health Service to enroll.
Okay, so Amy, it sounds like you don't actually have an answer about what the enforcement mechanism might be, but maybe that's something that we will be following up on to delve into that a little bit more deeply. And
we can certainly take that back and make sure that as we get the information from the consultations, take that back for consideration.
Yep, thank you. We have another question. Are American Indian Alaska Native communities part of state plans, or do we need to send in separate plans?
Right. I think that's a great question. And again, that's going to depend on who you're enrolling with. If you choose to enroll with the state, then you would work with the state to meet whatever planning requirements they are going to need to have for their sites to be COVID vaccine providers. And if you're working with the Indian Health Service, you would work with them to develop a plan for the administration of COVID vaccine. But Francis, did you want to add anything?
What I would add to this is I think it's important for programs and tribal programs to look at what is the existing process for vaccine administration now? You know, does it go strictly through Indian Health Service and you get your supply from Indian Health Service, or is there a county program or a state program that the tribe is working with? You know, what is the existing infrastructure? Because I think that's a real important piece to begin looking at this issue. Over.
Great, thank you. So I have another question. Are there priority communities, given what you all talked about with regards to limited supplies? Will there be a distribution to all communities?
So again, another great question, and some of these we will definitely need to take back and look forward to the regional consultations to get a better understanding of the questions and make sure we can respond appropriately. But one of the things that ACIP will be taking into consideration when they determine who needs to receive supplies and the initially limited supplies, we'll be looking at the burden of COVID disease, current activity with COVID, and those communities that may have been disproportionately impacted, and that will factor into the prioritization of the communities initially, but certainly the goal is for every community to have access to COVID vaccine. And I know I do have other folks from CDC who are on the line, and if they wanted to add anything, or Francis, of course, if you wanted to add anything, or Mary, and I don't mean to dominate the answers.
No, Amy, you're doing just great, and you're absolutely right. The ACIP process, the Advisory Committee on Immunization Practices, is really going to help determine the allocation process, particularly upfront, as Amy mentioned, when the supply of the vaccine is much more limited than the demand. And it will look at not only the factors of what Amy talked about, but also if there are any efficacy factors. So if the vaccine that gains approval is more efficacious for one population set versus another, that will factor into it. So that would be the only thing I'd add beyond what Amy has already very eloquently provided.
So Marianne, just to thank you for that explanation, and just to kind of ask a follow-up question. What I understood, I was on another call, and the example that was given with regards to your last statement was if a vaccine was more effective with, say, elders, then that would be the group that would be prioritized. If it didn't work for youth or that kind of thing, then there would be some kind of targeting of the groups that it actually works for. Is that correct?
Yeah, I'll jump in before Amy does. So yes, that is correct. So efficacy will play a major role in it. But again, ACIP will take all of that in consideration for not only the doses available, the priority of the vaccine, but then again, the efficacious properties of it. So yes, in that scenario that you described, yes. Amy, I'll defer to you for anything I left out.
Nope, that's great, thanks.
Okay, so I have a couple of other questions. I'll switch gears just a little bit here. Will the vaccines be finished with all phases of trial before they're distributed to the public?
Marion, did you want to take that one?
Yeah, I'll take that. And so I'm certainly not a clinician, and so I will tell you my understanding of it, and then I know Janelle is on as well, and she could probably jump on. Vaccines have to go into clinical trial stage 3. I believe there are scenarios where if there is more than adequate data to then send to the FDA, there could be a scenario where a vaccine trial, a limited scenario, where a vaccine trial wasn't 100% completed. Again, that's up to the medical professionals and then certainly the FDA. The goal of a clinical trial, and our clinical trials, is to have 30,000 people do the 2 shots. So the clinical trials that you see right now, people go in, they get dose number 1, and depending on which vaccine they're going to, then anywhere between 21 and 28 days later in the trial, they come back and get the second one. And so then there's going to be a period of time that's looked at after that second dose. Now, whether all 30,000 people get dose 1 and 2, that's certainly going to be up to the medical community and the scientists and the FDA. So I can't answer that fully. I'm sure there are scenarios where it may not be the full clinical trial, but I would defer to any of the doctors on the line.
Amy or Rear Admiral Fraser, would either of you like to add anything onto that?
I mean, I think the only thing I would say is that any vaccine that's going to be distributed will have to be authorized or approved by the FDA and meet whatever safety thresholds they have determined are necessary.
Thank you, Amy. We actually had another question.
Can I jump on that for a little
sure.
bit? Yeah, and Amy's absolutely right. So there's a lot of concern with vaccines, and a vaccine is not going to be released from a clinical trial without the appropriate level of safety and review, and then certainly medical review. So I don't think any of us on the line, as you had mentioned early on, Carolyn, are experts in clinical trial and how the full clinical trial is administered. But as Amy provided, any vaccine before it is released to the American public must either get an EUA, emergency use authorization from the FDA, or a BLA, a biological licensing approval. And that's really what we're looking to make sure is that before we introduce a vaccine to the American public, is it safe, is it effective for the American public?
Thank you for that answer. We have a few minutes left, and I'm going to try and get in a few more questions here. I do want folks on the line to know that we will follow up with all of the questions that you have entered into the chat box. And if we do not have an opportunity to ask and answer your question, NIHB will put these questions on our website with answers. We'll work with our panelists to get answers and to post them on our website. But in the last few minutes we have, I'm going to try and get to a few more. Will Operation Warp Speed make amendments to the playbook to include tribal recommendations?
So I'm going to defer that one to the CDC. I know that they put out that this was an interim playbook, but Amy, I'll turn that one over to you or to Janelle.
I can even answer it. This is Almia Matnock.
Okay.
Thanks. Yes, that is definitely part of the process that we want feedback on. There is a playbook that's been released, and I think that's on your website, right, Carolyn, already? So definitely looking for feedback to that, and that is a living document that we expect to be edited and updated, and recognize that in this area in particular, it needs additional information.
Thank you. And just as a reminder, all of those regional consultations will be taking place next week, and certainly there's the opportunity for tribal leaders to share perspectives and be heard by agency partners. So just kind of, again, please make sure that you share information with your tribes so that they are on those regional consultations next week. And National Indian Health Board has all of that information posted on our website. I have a couple of other questions. There's a question here: is there a preferred gap between when someone receives the flu vaccine, the regular flu vaccine, and the vaccine for COVID? Is there a preferred gap of time?
Almia, did you want to respond to that one? I mean, I think we don't, until we know what vaccine is being recommended, we're not going to have specific answers to those types of questions. I will just say at this time, co-administration of the COVID vaccine with other vaccines is likely not something that's going to be able to occur. But in terms of the ideal timing, that will really be something the Advisory Committee on Immunization Practices would certainly be looking at, and will provide guidance on that once we know what the vaccine is.
Yeah,
Almia,
Amy,
did you want to add?
Yeah, and I'm also, Francis, if you want to add anything to this, but I think in general, what is being encouraged now is for people to get their flu vaccine now, before there is COVID vaccine, to make sure that they're protected, knowing that these two viruses could exist together during the winter season that we're heading into. So I think there's that. And then, of course, there will be the question of whether the two can be co-administered, given at the same time, or if there needs to be any separation between the two. And that's something that ACIP is aware of and will weigh into once they have that data.
And this is Francis. Nothing to add.
Okay. I have another question. Will jurisdictions be recommended to open a point of distribution?
Almia, did you want to take that one, or Francis, or Marion?
Yeah, that one's I can't answer. I think that's going to be respective to the Indian Health Service planning or the respective state planning. So I'll defer to Francis on that.
And I'd have to research that. I don't really have a specific answer at this time for that.
And
again,
okay.
I do know that that is something that states in their planning. So if you're thinking about working with the state and you're considering that distribution mechanism in particular, that would be something that I would connect with them on as well.
Okay, thank you. And I have just a couple more questions to finish this up here. Is IHS and state enrollment mutually exclusive?
This is Francis Fraser. I'd have to defer to CDC on that question.
Well, the idea would be that you will choose one or the other. So you would not be able to be enrolled with both the state and the Indian Health Service.
Okay, thank you. And kind of on the same topic, will IHS publish the enrollment process so that tribes can weigh their decision between working with the state versus working with the IHS process?
We will we'll definitely take that into consideration when we're talking I guess I would like to get a little more clarity on what specifically what is being referenced to in the enrollment process. I think that would help answer the question a little more clearly. So if that could be, even, sort of clarified in the chat box, we can make sure to get a response back on that.
Yes, absolutely. Just kind of from the National Indian Health Board perspective, we have heard our tribal advocates asking for more details on the two pathways that are before them so that they can, look and compare if they are going with the state, what that looks like, if they're going with IHS, what that looks like. So I'm not sure that that's exactly what's meant in this question, but that's certainly something that we have heard, and trying to, have all of the information so that you can make an informed decision.
And I appreciate that. And this is Francis Fraser. Our goal is to be as transparent as possible, getting information put together and cleared within our incident command structure, and getting that out there for programs to review. So, that is our overall goal, to be, all of this is moving extremely quickly, and so I can say, we will turn information around as quickly as we can, so that both programs within the Indian Health Service, tribally operated health programs, urban programs, all have the most up-to-date information that we're putting out, so that they can make informed decisions.
Great, thank you. And I have one last question I will ask, and for the balance of the questions, I promise to our audience that we will get answers and post them on the website. One last question: are there enrollment deadlines?
I'll defer to CDC on that.
So I don't know that we have firm deadlines, because we don't actually know when the vaccine is going to be available, but states are working on their plans, and they do need to turn those into CDC for review by October 16th. And again, we really want to make sure that we are planning and ready to move quickly in the event that we do have a vaccine. But Almia, do you have any additional information regarding specific deadlines for making the decision? Oops. Oh, sorry. I see that Dr. Matnock is muted, but she's saying no, there's no additional information regarding that. Okay. Well, we have come to the end of our hour. I feel sorry that we were not able to get to all of the questions. We do have a lot of comments. This really gives us a sense that this is an area that we will be focusing quite a bit more on, to make sure that we are getting everyone the information that they need. I want to thank everyone for taking time out of their day to join us, and I especially want to thank our presenters today. It was really excellent information that you shared. Obviously, there's a lot of quickly moving components here, and we will be working to make sure that we get your updates and share them out with Indian country. And to that effect, we will be making this presentation available on our website, and we have slide decks. We will also post those. I know some folks in the chat box were asking about that. I wish everyone a very good afternoon and a good weekend, and I hope that you all please stay safe, and you will be getting some answers to those questions that we weren't able to answer on the line. Thank you very much. Thank you, Carolyn.
Thanks,
everybody.
Thank you.